Well, a big thank you to Ryan for working through those data books with us and helping bring out some of those important points as we think about the data that's coming forth to us. I am Shannon Canfield. I am the project director for the Missouri Health Equity Collaborative at the Center for Health Policy. Center for Health Policy is housed in the School of Medicine at the University of Missouri here in Columbia. And on that note, thank you all so much for coming to see us here in Columbia. I'm happy to say that it's not raining and that we won't all float away today. So again, thank you for traveling to be with us. I know many of you have come quite a distance. If I can get all right. So I want to just take a minute to talk a little bit about the Center for Health Policy and the Missouri Health Equity Collaborative, which you'll hear me refer to as MOHEC along the way. The mission of MOHEC really does fall right in line with the core values of the Center for Health Policy. And the Center for Health Policy was founded by Dr. Karen Edison, who hopefully you all will get to meet later today. She is the founder in 2002 and has worked alongside of many leaders in the university and through collaborators, many of you are here today, throughout the state to reinforce the values of the center. So along with the mission that you see here today for MOHEC, the center really does do important work to emphasize the importance of health literacy trainings, working on different projects that have to do with better understanding data that comes out of Medicaid and things like that, all with the purpose of working towards equity, policy, things like this that will help all Missourians achieve healthier lives. MOHEC really is in charge of the educational components, raising awareness, and you'll hear me say this several times today, but I really do feel like our job is to act as a conduit. So although MOHEC does do primary research and also secondary analysis of data sources that are out there, we really do rely on the collaborators throughout the Missouri, and many of you are sitting here in this room, to let us know what's going on the ground. So what are the projects that you all are working on that are bettering the communities, bettering the health of all Missourians? What are you all doing to decrease these inequities and these disparities that we're seeing throughout the state of Missouri? So with that, I think that we also need to say a big thank you to the Missouri Foundation of Health. They have supported MOHEC since its inception in 2004 and has been continuous supporters of us. So I appreciate the fact that the Missouri Foundation for Health and Ryan Barker reached out to us today to co-host this event so that we could share a little bit of some of the findings that we're coming across in our qualitative data studies. So a big thank you there. I also want to say thank you to some of the leadership on these specific qualitative studies. So Dr. Edison, Dr. Janetta, the Associate Director of the Center for Health Policy, Stan Hudson, and a key research associate, Iwana Stekulescu. Thank you to all of you for all your work and contributions for putting together these research programs. And again, we couldn't have gotten some of the data that we're going to be discussing here today without collaborations and partnerships throughout the state that allowed us to come into communities to pave those pathways for the communication to happen that allowed us to talk to some of the people that you'll be hearing from today through these quotes in the qualitative studies. So I just want to draw your attention, many of you may have seen the recent release of more transparency in some of our data elements. So we now have a better understanding, for example, of what it looks like for people to access healthcare services. We now have a better understanding of some of the different, across the board bills that are coming out based on location and services that are being put out there. That, access to insurance and costs that are coming, actual payment coming out of people's pockets definitely impact equity. We absolutely understand that. But to me, that's kind of a no-brainer. We absolutely need this data so that we can have good concrete policy changes. But as Ryan mentioned before, we need to be thinking very hard about those social determinants of health. And I know that you all hear this probably at every talk that you come to like this, but I am going to define the social determinants of health as stated by the World Health Organization. And that is the condition in which people are born, grow, live, work, and age. They are the circumstances shaped by the distribution of money, power, and resources on a global, national, and local levels and within all of our towns and community. And I think that it's very important for us all to remember that. Also, when we're talking about these equity and disparity issues, it's really important that we remember that these are unfair and avoidable instances. So that's why we're here today. We are talking about equity issues that are unfair and avoidable, and that's why we're all sitting here, because we're all working very hard to change some of these situations. So with that, I want to talk a little bit about some of the qualitative studies that are coming out of the Missouri Health Equity Collaborative and the Center for Health Policy. There are several qualitative studies, and I'm going to touch on two primarily today. And that is our qualitative studies really focused on the newcomer population of Missouri and also on the African American residents of the Boot Heel area. So the purpose of that is to really explore what access and utilization looks like from the people that we had the opportunity to speak with, what those experiences were like when people access services, and what resources were utilized by some of these participants. This was a study that was approved by our Institutional Review Board at the University of Missouri, qualitative research study, as I've mentioned, and we did perform a content analysis of these interviews. So with that, what are we defining as our newcomer population? Those are the refugees and or immigrants that live in the state of Missouri. We had 36 adults across St. Louis, Kansas City, and Southwest Missouri, representing 9 different countries, which included Iraq, Sudan, Somalia, Mexico, Cuba, Colombia, Ecuador, Guatemala, and Kenya. So quite a span of folks participated in this research study. I will say that a large portion of those interviewed were Spanish-speaking participants. We can see that we had a nice range of ages represented in these qualitative studies, all the way from 18 to over 65. Majority kind of landing in that age group of 30 to 39 years old. Primarily female, many married, and over half were in that 3 to 5 household numbers of in the household range. Across the board as far as educational attainment. So what we were looking at there was about 22% had made it through primary school. 17% had some high school, 17% had completed high school, 8% had some college, 22% had a college diploma, and 14% of those participants had a postgraduate degree. So now moving into some of the main findings of these qualitative studies. And the purpose of sharing some of these findings today is it really does, I hope, round out some of those quantitative data points that you were looking at earlier. It sort of is meant to provide the context that allows some of those data points to exist. So the main findings across the newcomer population: high cost of healthcare, no big surprise. Lack of insurance coverage. The complexity of dealing with the healthcare systems, and really the importance of communication, appropriate provider-patient communication. So I'll highlight some of those findings as we go. First example I would like to share with you all is an example of what it looks like from a participant's point of view when they do have coverage. It's great. You know, when I have medical insurance, it really helps me with my care. I'm able to go access the services that I need. This is, as the respondent says, this is private insurance. They can go to any doctor, clinic in town. And this person really felt like this did enable them to have better access to specialists and primary care providers. Now, with that, we understand that, in one of those first slides, social determinants of health is way more complex than just out-of-the-pocket funds. It's more complex than whether or not we have any type of insurance cover, whether that be private insurance, public insurance. In this example, it sort of gets at some of those complexities. This person was speaking about their daughter, who is 15 years old, who actually was approved for braces through Medicaid. Problem is there's a lot of costs associated that we don't necessarily think of when we think about people who actually do have coverage. This person actually had to drive over 2 hours to receive the services that they need for their daughter to have those braces. And they were being asked to travel that far every 6 weeks. Gas is expensive, and that is a long way to go every 6 weeks, taking time off work and things like that. So I think that we can all guess that maybe not every appointment was made, and maybe this person didn't actually, or this child actually didn't receive all the care that they needed. Another example of some of those real costs of care. This person spoke a lot about their large family that they had. They spoke about the fact that they didn't necessarily speak English as their primary language, or they didn't speak it very well. And in this person's case, their wife didn't speak English at all. They also had difficulties obtaining transportation and had to take off work in order to support their family when they needed to go to the doctor. So there's a lot of different things going on here. If they're going to travel, take off work to go see the doctor, they need to be sure that there are going to be interpretive services right there waiting for them. A lot of people cannot necessarily take that chance that they're going to show up at the doctor and not be able to get the services they need. So what do people say would help them? So in addition to some of these more obvious things that are coming out, transportation services and things like that, but flexibility is very important to people. A lot of people talked about when you are handed a huge bill or you are anticipating a huge bill, guess what? I don't think I need to go to the doctor that bad, right? So the opportunity to have payment plans and systems in place is very attractive to many people. However, it's important to note that in this study we found that people wanted to, again, much like the translation services, they wanted to know what to expect in advance, and they wanted those services and those payment options to be equally distributed across care providers. So they knew what to expect, they knew how to plan for their healthcare services that they needed. Another example of those complex challenges navigating the healthcare systems. This person's talking about a couple different things going on here. They're talking about needing specialty care. They're talking about not being able to pay a small copay of $15, and also managing some complex chronic diseases. So in this case, it would have been very nice to have somebody to help them navigate all those different systems that they were having to work through when they were trying to access care. So again, what would be helpful to some of the participants that participated in this study? Well, a couple different things. Having a healthcare broker, an advocate, somebody who really understands the systems, being able to either help arrange some of those services in advance, helping them understand what exactly they were eligible for before they went to the doctor, what types of payment plans, medication plans, supplemental plans were available to them and their situation. And they also wanted to clearly understand what they were not eligible for, so that you don't show up, seek services, and then get that $5,000 bill that was referenced earlier. They also wanted flexibility to be built into the system. So again, I mentioned payment plans earlier, but also just the understanding from the healthcare providers that maybe we don't schedule all 5 huge expensive tests all at once. Maybe we can spread those out over time. So, the scheduling of tests and things like that, so that that person can afford to pay for them as they need them, would be very helpful. And also flexible hours of care. Many of the folks that we had the opportunity to speak to were migrant workers. So there is not the opportunity to necessarily miss 3 hours of work in one day during the busy season. So having aftercare hours after 5 or weekend hours would have been very helpful from the point of view of these participants. Another big theme was, again, appropriate communication. Now, communication is one of those topics that I think we can all agree is huge. What is communication? Well, communication is everything, right? So I'm going to give you a comparing and contrasting couple of quotes here. In the first quote here, this person is talking about not having translation services available to them, what that means for their care, what that means for their likelihood to go seek care, and also when they get there, if those translation services aren't done well, then there can be a low standard of care. And I think a lot of people, from what we're seeing in this study, expect that in many instances. They expect if there isn't a trained translator to be there to help them understand the dialogue going on between themselves and their healthcare providers, that they're not necessarily going to get the same type of care as somebody who is an English-speaking patient. When there is a translator available, people talked a lot about how they had a great experience. I'm so happy that there was somebody there to help me talk to my doctor. And in this person I thought was quite exceptional because they mentioned when I have a problem, I go back and I ask again and again, and the interpreter will go back and ask those questions on my behalf to my doctor. So good job of example of health literacy and asking for teach back there. But a clear comparing and contrasting of what happens when those translational services exist or don't exist. In this example, I think we have another, this is one of those layers of communication. This person said that they really felt it was the provider's job to be in touch with various cultural norms of the patients that they are serving. It's not the patient's responsibility to have to teach the provider necessarily, hey, this is how we do things in my culture. So the patients really wanted to see more education, cultural competency coming out of their healthcare providers. Understanding of cultural norms, the ability for a person to understand instructions, all contribute to relationship building as well and have to do with consistency of care, not having delayed care and things like this. All right, support and education, and I think Ryan hit on some of these points as well. We need to be able to go into the community, and people are asking for this, and have clear education and support in the language of the person seeking that information so that they know how to deal with their diseases. They know how to move through the hospitals and things like this. So I need to wrap up the newcomer portion so I can talk to you a little bit about what we heard from our African American participants. In a nutshell, we heard we need help navigating these systems, and that is complex. We need people who understand how to work through insurance eligibility. We need people to help us understand how to get a cab, how to access office hours, how to work through those medication programs. Flexible payment options that they can expect across the board, no surprises. Interpretation and educational materials in native languages. Primarily what you find, if it's not in English, is it will be in Spanish. So for the populations that we did hear from, if it wasn't one of those two languages, you don't have those nice tools on the internet necessarily as easily accessible. With that, I will say that not everything automatically comes out in plain language, and I think we know that in any language. So, disease-based support groups within the community. So among community members, so you have the opportunity to share those experiences across the community, but also from your providers helping support those. And again, providers that really do understand cultural norms and are educated on that when they're providing services. So with that, I'll move on to some of the findings from our African American qualitative study that came out of the Boot Heel. This was a very small sample. We had a unique opportunity to speak with some folks through some of our collaborators. So keep in mind, small sample out of the Boot Heel. We did hear about some significant health challenges looking at our health disparity data books from the Boot Heel region. And so I think that this does provide a little bit of context around why some of that is happening. Okay, so I should also mention we asked very similar questions of these participants that we asked of the newcomers. So we asked, in general, what does it mean to you to live a healthy lifestyle? What does that take? And we also asked about barriers and facilitators to accessing healthcare services. I should describe our population a little bit. Okay, Boot Heel, across the board again with the age groups, 18 to over 65, although about 40% sort of landed in that 40 to 49% year old age group. Largely female population, many of the participants were married, and very high educational attainment amongst this sample. So 44% had some college and 38% had a college diploma. All right, some of the main themes that I want to discuss today. Difficulty identifying a provider. So that we will get into what that means, but having access to providers in general was a primary theme. What it means to access services that are available within the community, even though they were available, concerns around quality, trust, things like that came up as barriers to accessing services. And the desire to have strong support systems and built environment within programs and community structures so that people can live healthier lives. So what do we mean by difficulty in identifying healthcare providers? Well, it's really hard to get primary care providers in this region. There's just not enough help to go around. There's a perceived and I believe real shortage in this area. And what we were hearing from participants is that from the pool that does exist, there were some trust issues going on. I will get into some of these topics a little bit more as we go. Specialty providers, not a whole lot. Most people are going to have to drive to places like Springfield or St. Louis to get any kind of specialty care. Dental, not very much at all, even less than specialty. So I'm sure many of you deal with that in your work with the populations you're serving across the state. Dental is a problem as far as access. When dental was available, there were perceptions that the quality wasn't that great and that some of the medical equipment was outdated. All right, again, that idea of really complex challenges. So presenting this again so that we can understand, shape out some of those data points from the perspectives of these participants. So this person that you're reading about on the screen actually was very interested in monitoring some of their changes in their health status. So they wanted to look at their liver, they wanted to monitor their cholesterol levels and things like this. They perceived that they didn't necessarily have access to specialty care, and that the only place that they really could go was going to be the hospital. They perceived that was where you needed to go to get blood tests. This person also talked a lot about how, they're learning how to manage a chronic disease. So they were trying to figure out how to keep their diabetes under control. So what are we talking about here? Well, this person perceived that not only did they have access issues, but you know what, bottom line, the folks at the hospital, they wanted to know how they're gonna get paid. So this was a barrier to care. This has to do with, again, you don't necessarily care about my treatment, you just care about whether or not you're gonna get paid for your services. So that was a big barrier for this person. Another participant, when we asked about access to care, well, dental was easy. We don't have that here. Primary care, Although there are primary care providers, people, just figure when I have to go, I might as well take a good book because it's going to take hours before I can actually get in the door and see that provider. So that again becomes a big barrier to care. You're talking about people having to miss work, not necessarily believing they're going to have the time that they need with their provider, that these providers are overburdened to begin with. What did these participants think would be helpful? Well, they want more providers in their area that could see them. But not only that, not only do they want to relieve some of that heavy burden on their caseload, they want providers who really identify with the community. So in order to serve me and to really understand my issues, you need to understand what's going on in my community. You need to understand the cultural norms going on here. You need to understand all those little bits that really do define who I am and who my community is. And I think from this participant's perspective, that also had a lot to do with retaining providers in that area. They recognize that, hey, these providers have a hard job ahead of them. So we need to find somebody that's very passionate about this community to keep them around. Earlier I mentioned trust as a barrier to care. Some participants mentioned that although there were some primary care providers available to them, that this was a very small town. And despite the Hippocratic Oath and despite all confidentiality rules and regulations, these participants expressed that they felt like, information that is supposed to be safe and confidential and private will get out into the community. And this was a big barrier to accessing care. The last point that I want to hit on is the genuine desire to have all the resources people need to live healthy lives. I think this quote is a great example of a person saying, listen, I want to take care of every aspect of my whole person. I want to take care of my body, I want to take care of my mind, and I want to take care of my spirit. But they need to have access to facilities, support groups, education, grocery stores, sidewalks, safe lighting in order to do that. They would like to have the opportunity to have some type of community center like the YMCA to go and actually be physically active, things like that. I think it's very, when we start looking at health outcomes, it's easy to forget what it means to not have streetlights when you live in a neighborhood that doesn't feel safe. It means you're not going to go out. It's not for lack of desire. It's not because you're lazy and you don't want to get up off the couch. It's because it doesn't feel good and safe. So thinking about all those aspects of built environment becomes very important. What did these participants say would be helpful to them? And specifically around thinking about taking care of themselves. They wanted to have more information about managing chronic diseases. They wanted to better understand what it would mean to enroll in healthcare programs. So across the state, we're hearing that people really need help understanding what's going on. And people need help understanding how to navigate the changes that are happening as well. And again, transportation comes up in every population that we look at with our qualitative studies. I think I need to get close to wrapping it up. I wanted to have enough time to present on another qualitative study that I think would be of interest to many of you, which is on the provider perspective on caring for newcomer population. However, we're short on time today, and you have the opportunity to come to the Cambio de Calors conference in St. Louis on June 12th to 14th to hear about more of these challenges facing people and some of the innovations and exciting research coming out about it. So please do come see us at Cambio, and you'll hear about the provider perspective of caring for newcomers across the state of Missouri. We had the opportunity to speak to, I believe it was 35 or 36 providers from a broad spectrum of healthcare settings to get a better understanding of their challenges, their perceptions of providing healthcare services for people living in Missouri. I will give you a little bit of a sneak peek of some of the main themes that did come out of that qualitative study. Communication. Communication is key. So when we're thinking about the newcomer population specifically, it's the ability to anticipate demand for interpretive services and rely on those being available and ready. They also talked a lot about, well, what happens when interpretive services exist? What are the key themes around training opportunities for providers, the quality of training of the interpreters? What happens with the rest of the staff? What happens when you have a bilingual staff? So what happens when those services do exist? What happens when they don't exist was another key theme. Who does the interpretive services? You know, a lot of times a kid would be pulled into that appointment. What does that mean for quality of care? Again, with communication, that is multifaceted, and we hear a lot about what does the impact of culture mean? What does a provider's understanding of that person's culture mean to their ability to provide the care and services that are needed? Also, what does the opportunity for building relationships between patient and providers mean? And what is the role of communication for that? We also talked a lot with providers around the issue of access to care. And so we have significant findings on what it means to them to provide care to patients that have significant barriers. What does that mean for their ability to deliver healthcare services? And also, what is the role of trust when thinking about the provider-patient relationship? And I think, as you can all imagine, in thinking about all the equity issues that we're talking about today and some of the barriers we're facing, trust is very important. So with that, I would like to say thank you all for listening to me today. And I think that we have a little bit of time to take some questions before our next speaker.